Hi, my name's Hannah Hollingsworth, and I'm the PGY2 resident at Hospice of Southern Illinois. Today I'll be presenting on management of nausea at the end of life. To begin with, let's talk a little bit more about nausea. So the prevalence in the end of life population or palliative care population tends to be estimated at 16 to 68%. So I know that's a really wide range, but it does, again, widely vary, and it's complicated by factors such as the ability of patients to communicate this symptom with different healthcare providers. It is more common closer to death, with one study reporting 36% of patients having nausea at first contact, 62% of patients at 1 to 2 months, and then 71% of patients in the final week of life. There is another study that also showed that, again, since it's more common closer to death, it may predict shorter survival of these patients. It's typically intermittent and mild to moderate in severity. So while it can be severe nausea, that is not as common to see. It is reported to be commonly undertreated, even in severe nausea as well. Some definitions to review include nausea, which is the sensation or sensations preceding vomiting, but this is not always associated with vomiting. This is a subjective occurrence, so it is harder to identify when patients are nonverbal or if a patient has limited verbalization. Some patients may describe it as a queasy stomach or a sick stomach, but in those nonverbal or limited verbalization patients, we may watch out for grabbing at the abdominal area or rubbing their stomach or abdominal area. Vomiting is the retrograde expulsion of gastric contents, and this is not always associated in nausea. So they can occur alone. They don't always have to occur with each other. And this is objective, as we can see patients when they are vomiting. You can see the vomit. Retching is also a separate definition, and this is really considered more as dry heaving, and that can occur with or without vomiting. To review the pathophysiology of nausea and vomiting, it can be kind of complex, but this diagram to the right kind of tries to spell it out in a visual way. And so we have the cerebral cortex, which may be triggered by anxiety, and this is really mediated by the gamma aminobutyric acid or GABA receptors. We also have pressure receptors, which may be triggered by conditions such as raised intracranial pressure, which may be triggered by, inflammation, for example, definitely contributes to that. There's also the chemoreceptor trigger zone, or the CTZ, which is definitely important in the pathophysiology of nausea and vomiting. And we can see that may be triggered by, drugs or biochemical changes within the body, such as changes in electrolytes such as potassium or sodium, and these are mediated by dopamine and serotonin. We also have the vestibular component, and this is really triggered by movement, and it doesn't have to be a lot of movement, as I think is typically thought of with motion sickness, for example. It could just be as simple as moving a patient around in bed. And this is mediated by histamine and acetylcholine in the body. We also have the gastrointestinal tract, which plays a role in nausea and vomiting. And this can be triggered by gastric stasis, constipation, as well as bowel obstruction, all of which, especially constipation, are common in our hospice and palliative care population. And that is mediated by dopamine and serotonin receptors, similar to the CTZ. There's a lot of different causes of nausea and vomiting. So just to review, a mnemonic that might help you remember is vomit. So V stands for vestibular, and that's, again, motion sickness. O is obstruction, which can be opioid-induced constipation, anticholinergic related constipation, so our patients on Lebsin, for example. Or it could be, mechanical obstruction as well. That can cause a lot of nausea and vomiting. M is for mind, and that is, really looking at the anxiety, depression, an altered taste component. So appetite can be stimulated by, pleasant sights, smells, and tastes, and a lack of these senses or altered senses can exacerbate nausea. And we see that nausea can also be worsened by anxiety and depression, which fall into this component or this section of mind. And I stands for infection or intracranial pressure. So this can be caused, the intracranial pressure can be caused by brain metastases or traumatic brain injury. And then T stands for toxins. So we're kind of looking at our CKD patients, especially our end-stage renal disease patients who may have a buildup of those toxins or unbalanced electrolytes, for example, in their body. We also see this with liver disease patients, have more of a buildup of these toxins in their body because they're not able to eliminate them or process them. And then toxins can also include drugs. And we'll talk about that a little bit more in a second. So I want us to also consider the reversible causes of nausea and vomiting. And the reversible causes include constipation. So again, this is a super common symptom in pain, in palliative care management, and typically easily treated with the right medication. I put a question mark by GI obstruction and dehydration because although they can technically be reversed, that might not always be possible with our hospice end-of-life population, and it may also fall outside of the goals of care, really, or the plan of care, to rehydrate a patient, for example. That's not typically something we do, at least not aggressively. We may encourage a patient to drink more water if they're able to, but we definitely don't force it upon them. GERD and dyspepsia are also reversible causes, so we obviously have our medications such as, pantoprazole or Pepcid that can treat GERD and dyspepsia, but we also have non-pharmacological options for treatment too, and this could be avoidance of triggering foods such as high-fat foods, spicy foods, chocolate, mints, and caffeine, just to name a few. Trying to encourage patients to not eat too close to bedtime, so trying to avoid eating 2 to 3 hours before going to sleep at night, eating more slowly, avoiding overeating, as well as elevating the head of the bed by 4 to 6 inches if possible to try and reduce the reflux of gastric contents that may be exacerbated by a horizontal body position. Infection can also cause nausea and vomiting, and this may be treated with antibiotics if appropriate. Anxiety can also contribute to nausea and vomiting, although this is a little bit more rare to find. And then we also have, again, our drug-induced causes. And this, I also wanted to mention that this is not just prescription drugs, but can also be illicit drugs. So including the use of cannabis, which can lead to cannabis hyperemesis syndrome. Looking a little bit more into drug-induced nausea and vomiting, some common offending agents that we see include opioids, which is a very commonly used medication in our end-of-life care and hospice population. Selective serotonin reuptake inhibitors, or SSRIs. So for example, Lexapro is an example of this, can cause nausea and vomiting. We have different supplements that patients often use, such as calcium and iron, which can cause stomach upset. The NSAIDs, such as ibuprofen, meloxicam, can also cause stomach upset. And then digoxin and phenytoin are two medications which I personally feel as if they are not that uncommon to see in our hospice population. And these medications, a sign of potential toxicity, because they do have a narrow therapeutic index, is nausea and vomiting. Additionally, with digoxin toxicity, there might be visual disturbances such as blurry vision, yellow coloring of the vision, or halos around objects. For phenytoin toxicity, some additional signs and symptoms include nystagmus and ataxia. For assessing nausea and vomiting, unfortunately, there's no real standard tool for evaluating nausea and vomiting, but as far as the HSI assessment procedures go, during each assessment, we want to assess for the presence of nausea and or vomiting. If there is nausea or vomiting present and currently controlled with an antiemetic regimen, then we want to document this in the patient's electronic medical record. If the patient is unable to communicate, which is common in our hospice population, we want to utilize caregivers and or facility staff to see if they have noticed anything that might indicate the patient is experiencing nausea, or inquire about any episodes of vomiting. If nausea, vomiting, or both is present or suspected, the nurse will then assess and document yes or no in the nausea field within the EMR. For treatment of nausea and vomiting, we have pharmacological options as well as non-pharmacological options. So to briefly just list off our pharmacological agents, and we'll go into each of them in more detail, they include dopamine antagonists, serotonin antagonists, prokinetics, corticosteroids, benzodiazepines, and anti-secretories. So really, depending on which one you would use depends on, the patient-specific considerations, although there are definitely times when it's appropriate to just do empiric treatment with a certain agent. For our non-pharmacological options, we have distraction, guided imagery. If we know that the nausea and or vomiting is being triggered by something such as an unpleasant smell or taste, then we want to try and remove the offending stimuli if possible. There's also progressive muscle relaxation, which may help relieve symptoms, and as well as massage. And a couple of the things I was reading about massage actually showed that foot massage specifically can be helpful for nausea and vomiting, although a lot of these studies were done for patients who are undergoing chemo and not necessarily just in hospice care or end-of-life situation. So before really diving into each of the specific groups of pharmacological treatments, I did want to kind of review their receptor affinities of at least a few of them. So there are really four main receptor sites that I want to talk about. So we have our dopamine antagonists, we have histamine antagonists, muscarinic antagonists, and serotonin antagonists. And so in this table, it's color coded so that you can see which agents have high affinity, moderate affinity, or low affinity for each of these receptor sites, essentially. And if it's a white space, that means that there's not really any affinity for dopamine or histamine or muscarinic or serotonin. Ondansetron has high affinity as a serotonin antagonist. Haloperidol, pretty much purely dopamine. Prochlorperazine, we really see moderate affinity for dopamine, and then low affinity at histamine. Promethazine kind of hits a couple of different spots. So low affinity for dopamine, high affinity for histamine. So it's primarily a histamine antagonist, and then moderate affinity as a muscarinic antagonist. And then for metoclopramide, we see most of the affinity at the dopamine receptors, so as a dopamine antagonist, and then low affinity for serotonin. Looking at our dopamine antagonists, the way this group works is that they block the effects of dopamine at the chemoreceptor trigger zone, as well as the gastrointestinal tract. So additional anti-muscarinic and antihistaminergic effects can also be seen as kind of described in that table on the previous slide. And we have a couple of different preferred formulary drugs that fall in this category. So haloperidol, typically at lower doses, can be used. Prochlorperazine is commonly used, as well as promethazine. Haloperidol specifically is commonly used throughout the nation in palliative care population. And really, unfortunately, there's more of a potential barrier to use, especially in nursing homes. And this is really due to CMS quality measures that aim to reduce the use of antipsychotics in nursing homes. So although it is commonly used in the palliative care population, it may be harder to implement. There are some adverse effects that come along with any drug, obviously, but specifically for this group of drugs, we can see extrapyramidal symptoms, we can see sedation and hypotension, tremor, and dry mouth. Although I put the asterisks by sedation and hypotension because this may be less common for haloperidol and prochlorperazine, and that's because promethazine has more antihistaminergic action, which can cause more sedation, for example. Different warnings also come along with this group of medications, including, we want to avoid it in Parkinson's disease. It's actually contraindicated because it can worsen Parkinson's symptoms significantly. We also worry about QT prolongation, and if the QT interval gets prolonged too much, then we can increase the risk for a dangerous or deadly heart rhythm. And so we want to be especially careful when prescribing these agents in addition to other medications that can prolong the QT interval, such as our fluoroquinolone antibiotics, for example, such as Levaquin. These medications also come with the warning for the neuroleptic malignant syndrome, or NMS. And this syndrome, we really want to monitor for mental status changes, fever, muscle rigidity, or autonomic instability. Those could be signs that this syndrome is occurring. So risk factors for the development of NMS include high doses of neuroleptics. So thankfully, usually, especially with haloperidol, we don't have to worry about this as much because the doses used for nausea is much lower than the doses used for, antipsychotic purposes. Other risk factors include rapid dose escalation or the IV route of administration. So again, in our hospice patients, unless they're inpatient, we're not going to be administering drugs by IV. And then coexisting conditions such as agitation and dehydration can also increase the risk of this syndrome happening. We also want to be careful with patients who have seizure history because these medications can lower the seizure threshold and increase the risk of having a seizure. So looking at the dosing of these different medications, haloperidol typically, starting off at a pretty low dose, 0.5 milligrams every 4 to 6 hours, just as needed. For prochlorperazine, it's 10 milligrams 3 to 4 days as needed, and promethazine is 12.5 milligrams Q 4 to 6 hours as needed. Something to note with prochlorperazine is that this dosing that I listed here is for the tablets. So the suppositories aren't really on our formulary, and that's because they're much more expensive than the tablet version. And the tablets can be inserted rectally for administration. So if a patient, though, did have prochlorperazine suppositories, the dosing is different. It's 25 milligrams BID as needed, but it is preferred at Hospice of Southern Illinois to use the tablets because they are much cheaper and still effective. For administration, all of these, again, are oral unless, a rare situation where it may be more appropriate to use the actual suppository version of promethazine or prochlorperazine. The onset, haloperidol, less than 3 hours because that's about when the peak occurs. I couldn't find an exact estimate of when the onset was. Prochlorperazine onset is 30 to 40 minutes and promethazine is about 20 minutes. For our serotonin antagonists, the way those work is that they block the effects of serotonin at the CTZ as well as the GI tract. And our preferred formulary agents at HSI is ondansetron or Zofran. These medications are typically well tolerated, which is one of the reasons why they are commonly used. To note, though, there's lots of evidence for their use in chemo-related nausea and vomiting. However, there is a lack of evidence for their use in palliative care. And they are more expensive than many of our other agents used for nausea and vomiting, especially the orally disintegrating tablet version of ondansetron. That can be 2 to 3 times the cost of even just the regular ondansetron tablets. For adverse effects, we see constipation, which, as we've talked about, constipation in and of itself can exacerbate or cause nausea and vomiting. We can see headache as well, fatigue, drowsiness, and anxiety. So while there are adverse effects to consider, again, they're typically well tolerated, and that's why we see them used more often. Some warnings include QT prolongation, so again, avoiding those other medications that can also prolong the QT interval, or patients who are already known to have a prolonged QT interval, avoiding the use of ondansetron in those patients. And because ondansetron can increase the levels of serotonin in the body, we also want to consider serotonin syndrome, although this would be considered a rare potential severe side effect. We may want to be especially more watchful for patients who are also taking antidepressants that can increase the levels of serotonin in the body and thus increasing the risk for serotonin syndrome. For dosing, ondansetron starting off at 4 milligrams every 6 hours as needed is definitely reasonable. We do want to reduce the dose for patients who have severe hepatic disease, and that's because it is metabolized through the liver and has a longer half-life elimination in hepatic disease, and we want to avoid accumulation if possible. For administration, we prefer the oral regular tablets. ODT should only be used if a patient cannot tolerate swallowing whole tablets. And again, that's really because the ODT formulation is much more expensive than the regular tablets. And we need to remember that even with the ODT tablets, while they disintegrate in the mouth, they still have to be swallowed by the patient. So swallowing ability still needs to be intact for ODT use. The onset is about 30 minutes. Moving on to prokinetics, the way prokinetics work are that they stimulate motility in the GI tract, and then they also have dopamine and serotonin blocking effects at the CTZ and GI tract. Additionally, they have utility for nausea and vomiting that is related to GI stasis. Our preferred formulary drug is metoclopramide, or Reglan is the brand name. So some ways we might be able to identify GI stasis are patients who have early fullness, who are vomiting undigested food, who are bloating, or patients who might report heartburn, especially if in conjunction with some of these other symptoms I just mentioned. Adverse effects that we want to watch out for include drowsiness, dystonia, which is dose and age related. So higher doses and older age are risk factors for dystonia occurring. Extrapyramidal symptoms, kind of falls into this category as well. Fatigue can also occur, as well as GI upset. So some warnings we want to consider include, again, seizure disorder. So it can lower the seizure threshold, so kind of being watchful for patients who have a known history of seizures. It's preferred not to use it for patients who have complete GI obstruction or colic because it can worsen that and potentially increase the risk of bowel perforation, which would not be good. Tardive dyskinesia can also occur, and this is a serious movement disorder that is often irreversible, and there's not really a known treatment for it. The risk of tardive dyskinesia increases with the duration of treatment as well as the total cumulative dose. So we want to avoid treatment with metoclopramide for periods of longer than 12 weeks if possible because of the increased risk of developing this syndrome. We also want to watch out for neuroleptic malignant syndrome, similar to our, haloperidol, promethazine, prochlorperazine, as I talked about earlier. And then there are also hepatic disease dose limitations that should be considered with metoclopramide. For the dosing of metoclopramide, it's 10 milligrams every 4 to 6 hours as needed, and that's going to be oral administration, and we can expect to see the onset of that medication within 30 to 60 minutes. Again, remembering not to use it in patients with confirmed or suspected complete mechanical obstruction. I want to mention that a few times because we worry about the safety of patients, and potentially, again, them experiencing a perforation if we're using this medication. For our corticosteroids, these really work by decreasing inflammation, and our preferred formulary drug is dexamethasone. It may be beneficial in raised intracranial pressure, again, by kind of decreasing the inflammation. So some risk factors for raised intracranial pressure include brain metastases, traumatic brain injury, intracranial bleeding, infection, which can include brain abscess or meningitis, and then encephalopathy. And with encephalopathy, the more acute the encephalopathy, the more likely the intracranial pressure is to raise. We may also see that symptoms, patients may report that their symptoms are worse in the morning, so the nausea and vomiting is worse in the morning, especially if accompanied by like a severe headache or a bad headache. Some adverse effects we want to watch out for include fluid retention, changes in mood, sleep disturbance, hypertension, weight gain, hyperglycemia, and GI upset. So it's definitely not without their side effects. Warnings to consider include adrenal suppression, and so withdrawal and discontinuation of a corticosteroid such as dexamethasone should typically be done slowly if possible, especially if the patient has been taking the steroid for longer than 2 weeks. And again, that's really because we worry about adrenal suppression. It can also cause immunosuppression, and so for patients who already have pre-existing immunosuppression, it may be best to avoid if possible, or at least watch them closely for signs and symptoms of infection. Dexamethasone can also cause, changes in mood or psychiatric disturbance, and so patients who already have pre-existing psychiatric issues, again, it may not be the best agent, or you may want to consider watching them very closely. Dosing of dexamethasone is 4 to 8 milligrams daily. 4 milligrams is a pretty low dose. Typically, patients, I would expect them to need higher doses than this, but it is a good starting place. Really, with most medications, I would say starting low and titrating to effect is an appropriate approach. It is an oral tablet, and the onset is less than 1 to 2 hours, and that's really the peak of the medication is 1 to 2 hours, so I would expect that the onset would be shorter than that. Looking at our benzodiazepines, the way these work is that they have anti-anxiety effects through enhancing inhibitory effects of GABA within the body on the CNS. So preferred formulary drug would be lorazepam, or Ativan is the brand name. And while we do have other benzodiazepines on our formulary, lorazepam is better in liver disease, and potentially less worries about toxicity or overdose potential compared to alprazolam, for example. And these drugs may have benefit really for anticipatory nausea and vomiting. Their utility in other types of nausea and vomiting is very limited, especially as far as the evidence we have for their use. There's really little, if any, evidence for use in non-chemo or post-op related nausea and vomiting. So I would really consider these last line unless there's a clear link between the anxiety trigger and nausea and vomiting occurring. And this is really, because, again, the benzodiazepines are not without their risks, especially in our elderly population. So adverse effects we want to watch out for include sedation, respiratory depression, and these first two, sedation and respiratory depression, I would say especially if the patients are also on opioids, which is not an uncommon combination to see in our hospice care population. Dizziness can also occur, confusion, delirium, and weakness. Some warnings to consider: we may see a paradoxical reaction, including hyperactive or aggressive behavior, which have been reported with benzodiazepines, especially in adolescent or younger populations, but also psychiatric patients. We also want to worry again and watch out for concomitant use with opioids due to that increased risk for oversedation and respiratory depression, which can be dangerous and potentially fatal. We worry about these medications increasing the fall risk to our population, especially our elderly population. And these medications can also cause withdrawal, so they may need to be tapered off if we are discontinuing them. For their dosing, lorazepam starting off at 0.5 milligrams Q4 to 6 hours as needed, again with lorazepam being our preferred benzodiazepine, but I did want to include some dosing for alprazolam, and I would say a reasonable starting dose for alprazolam would be 0.25 milligrams every 4 to 6 hours as needed. The administration is oral, but keeping in mind that these medications, can be crushed and mixed with a little bit of liquid in order to be administered, if that makes it easier for the patient. The onset, both of these medications, lorazepam and alprazolam, are considered intermediate onset, meaning that they're going to start kicking in about 30 to 60 minutes after swallowing them. We also have our anti-secretories, and the way they work is by decreasing secretions into the GI tract, and this is going to relieve nausea as well as the volume of emesis in some of our patients. So where we really see these coming into play and being useful is for patients who have terminal bowel obstruction. And then antimuscarinics can also relieve colic or kind of that crampy feeling that patients may get. And our preferred formulary agent is hyoscyamine or Levsin. Keeping in mind that these agents are really to be used as adjunct therapy, not monotherapy or on their own. Adverse effects include dry mouth, constipation, confusion, tachycardia, blurred vision, and urinary retention. Warnings, looking at, GI obstruction, especially if a patient has a complete GI obstruction, these medications can worsen that. It can worsen psychosis or cause psychosis due to its effects in the CNS. For cardiovascular disease, we want to use with caution in patients who have CV disease, such as tachyarrhythmias, heart failure, even hypertension sometimes. And its use is contraindicated in patients with unstable cardiovascular status or myocardial ischemia. So that's not as common to see with our patients, that really acute process, but we still want to be careful with patients who do have chronic CV disease. Oral effects should also be considered, so prolonged use of these agents can cause cavities as well as candidiasis, and just in general discomfort due to decreased salivation that can cause dry mouth. For dosing of hyoscyamine, it's 0.25 milligrams every 4 to 6 hours as needed to start off with. That may also be scheduled if we find that the patient does get benefit from it. And again, in conjunction with other antiemetics, not used on its own, so we may use it with haloperidol plus dexamethasone in a patient with terminal bowel obstruction. For administration, we can administer it orally, so they can swallow the tablet whole, and hyoscyamine can actually be administered sublingually as well because they make tablets in that formulation. The onset is listed as 2 to 3 minutes, although I suspect this is probably for the sublingual formulation, as that might be absorbed a little bit more quickly. However, I would suspect that with the oral formulation, just swallowing the tablets whole, I have seen it reported as closer to 30 minutes for the onset of action. Looking at our different routes of administration, so I know I've kind of talked about this throughout, but we have obviously our oral route of administration. So this is for whole tablets. We also have, again, the orally disintegrating tablets, or ODT, such as ODT Zofran. And remembering that patients must have the ability to actually swallow this medication still. This medication is not being absorbed sublingually. We may see that emesis is triggered by swallowing tablets, or that a patient vomits soon after swallowing a whole tablet. And this would be an appropriate situation to switch to the ODT formulation. There's also perirectal administration, so this is when patients lack the ability or do not tolerate oral route. Again, we prefer to administer as a plain tablet, so for example with promethazine and prochlorperazine versus the suppository formulations, and that's because the suppository formulations are much more expensive. So for example, a 2-day supply of suppositories can cost over $100. Whereas, the same day supply of the plain tablets is going to be less than $10. And we want to avoid, however, perirectal administration in patients with low platelet counts. And that is really because we are worried about causing a tear or bleeding in patients who have low platelet counts if we're administering something perirectally where the skin is much more delicate. There's also intravenous or IV route of administration, and this really just applies to our general inpatient population, as patients who typically are at home or in the nursing home are not getting IV medications. There are some different challenges with using a more directed approach to antiemetic treatment. Often multiple factors are leading or causing the nausea and vomiting, including pathways that are not treated by or not possible to treat by antiemetic medications. A cause may not even be identifiable in some of our patients, and in fact, many reviews and studies report that probably for the majority of patients, you can't really identify a cause. There's also a question around the evidence for, source-directed treatment versus empiric treatment. So we have to consider that as well. Also, empiric treatment and adjustment as needed is definitely more appropriate for our patients who are death imminent than trying to spend the time and resources, to really find, what is causing their nausea or vomiting. We may save time and provide faster relief to the patient by implementing empiric treatment, and if one thing fails, moving on to the next option. So in this final slide, I really just wanted to show you guys the treatment algorithm that we are going to be implementing at Hospice of Southern Illinois. So it starts up at the top where it's bolded, asking if the patient can swallow. So if that's no, then we move on to our rectal administration options. If the patient can swallow, then there's a whole cascade of different options that we kind of can go through depending on how we answer these questions. So is there a main identifiable source to the nausea? If not, no, then can the patient tolerate swallowing whole tablets? And depending on that answer, you're either going to use ondansetron whole tablets or you're going to use ondansetron ODT tablets. If there is a main identifiable source to the nausea, then we want to ask ourselves, is the patient death imminent? If they are, then again, we're going to use empiric treatment. But if they're not death imminent, then we're going to ask ourselves, is the cause correctable? Is it any of those reversible causes I talked about previously, such as constipation? If the cause is correctable, then we want to try correcting that underlying cause. But we can also provide short-term, for example, Zofran if needed to kind of get them through that period where we're trying to correct the cause. And if the cause is not correctable, at least not that we know of, then we are going to pick treatment according to the cause of nausea and vomiting if we can identify it. So that would be suspected raised intracranial pressure, gastrointestinal obstruction, gastroparesis, opioid-induced nausea and vomiting, and then anticipatory or anxiety-induced nausea and vomiting, and selecting our treatment based off of those causes. Finally, I wanted to review some of the key elements of the HSI antiemetic SOP. So when in order for an when nausea is first reported, utilize the treatment algorithm for initiation and subsequent changes. Patients who are admitted with ondansetron ODT, we want to change to ondansetron tablets when refills are needed. Often, many of these patients who come in with Zofran ODT, they are swallowing other tablets just fine, so there's not really a strong reason for them to continue using the ODT formulation. For prochlorperazine and promethazine suppositories, we want to change to tablets and administer perirectal when refill needed if the patient came in using the suppository formulation. And then for assessment, of nausea and vomiting, we want to include the number of doses of the antiemetic used in the last 24 hours, and then document that in order to determine if further action is required. And that's all I have for you guys. As always, if there are any questions or concerns, always feel free to reach out to me and I will address them as best as possible. Thank you.